Hello everyone, welcome to your lecture on patient safety and quality. These are the objectives we will be covering in this lecture. So let's talk about safety. What is safety? According to the Health Organization, the definition of safety is the prevention of errors and adverse effects to patients associated with healthcare. As part of the healthcare team, professional nurses engage in all activities that support a patient-centered safety culture. So safety is basically the freedom from psychological and physical injury. It's a basic human need, right? According even to Maslow's hierarchy, it's a basic human need. Individuals seeking healthcare, regardless of the setting, they present, numerous conditions that place them at risk for being unsafe. For example, barriers to safety can be in their workplace and the environment they live in, their own comorbidities, like their health conditions, their attitudes and beliefs about safety, even their economic resources affect the person's safety. Now, in a healthcare environment, the presence of individuals with infectious disease, for example, a patient comes to the hospital for, maybe a stroke, but there's a person next door who has, an infectious disease. Now they're, exposed to that. So the patient's own health conditions can be a safety risk. The layout and barriers within the healthcare system and infection control practices of staff members and nurses all affect, the person's vulnerability to some form of injury. So that's the reason why reducing the risk of harm associated with the way we deliver healthcare is a national healthcare priority. Patient safety is the primary drivers behind healthcare staff education, clinical practice guidelines formation, and policy and procedures. The regulatory agencies that are in charge of safety are Centers of Medicaid Services and the Joint Commission with their national patient safety goals. What is a vulnerable population? It's a group of people who are more likely to experience poor health and may face additional barriers to accessing services. So they have more likely, they're more likely to face these barriers compared to other people. So this group involves infants, children, older adults, individuals with chronic diseases and physical and mental disabilities, individuals who have difficulty communicating, individuals who have a low income or are homeless. So these are our vulnerable populations. So let's talk about the safety in the environment of the patient. This is the environment they live in, they work in, they're socialized in. What are some of the environmental safety hazards? You have basic human needs. They're basic human needs. Oxygen. Some patients go home with oxygen, supplemental oxygen. They need to know about safety with oxygen use. Environmental factors that decrease, oxygen, like furnaces, fireplace, and stoves. These decrease the oxygen in the environment and can cause carbon monoxide poisoning. So these are important points of education to provide to patients who need supplemental oxygen. Nutrition, the knowledge of healthy foods, food safety and storage, safe preparation and storage of food, food poisoning prevention, like just storing meats separate from vegetables, using different cutting boards, using different utensils. So all of these are important safety concerns with nutrition that patients need to be educated about, right? Temperature, like the temperature extremes, we need to educate our patients about how to adapt to like extreme cold temperatures or hot temperatures, like, for example, here in Arizona, it's extremely hot. Staying hydrated, covering your body, not exposing yourself to the sun so much, the times of the day that are safe to be outside if they want to walk or hike or, go be outdoors. So these are important education, topics that our patients need to know. Safety in the environment, environmental hazards, motor vehicle accidents. We all are familiar with motor vehicle accidents and the impact that they have here, especially in Phoenix, right? We have a lot of car accidents, right? We need to educate our patients about the use of seat belts, how, airbags, laminated windshields, helmets. If they're going to ride a bicycle or motorcycle, wear a helmet. We see that in Arizona a lot. We see people riding motorcycles and they do not wear helmets. And, so we need to teach them about accident prevention. Age-related, for example, older adults. They have declines in vision, cognitive functioning, physical ability. So they're more at risk for, getting involved in a motor vehicle accident. So it's important to educate on regular eye checks, avoid night driving, take safe routes, avoid distractions when they're driving, consider alternatives to driving, maybe carpooling or public transportation, something like that. Poisoning. Poison sources, their medicines, cleaning products, gas vapors, lead poisoning. How do they get exposed to this? Patients get exposed through swallowing them, inhaling them, especially in younger children. That's the reason why we always say keep, these detergents and cleaning products, in higher, cabinets that are higher so that children cannot reach it, or keep them in locked cabinets. Fire safety, improper use of equipment and appliances in the house, like the heating, portable heating devices, they're always catching on fire. And so teaching them about safety with that, fire safety, fire prevention strategies. Other environmental hazards are natural disasters, floods, tornadoes, wildfires, tsunamis. They can cause death, injury, homelessness. Then you have bioterrorism, use of biological agents as weapons. Like we had that case with asbestos, right? And so we need to, be vigilant at that, and we need to educate our patients to be prepared for natural disasters. Over here in Arizona, we have, during the monsoon, we have, issues. Then we have dust storms. Educating our patient about dust storms and how they impact their health, how to stay safe when there's a dust storm warning. Then we have transmission of pathogens, any microorganism capable of producing illness. Transmission is most commonly done through hands. So teaching them about hand hygiene, isolation precautions. So if they have friends who they socialize with who are sick, just isolation precautions, washing their hands, things like that. Falls are a huge barrier, are a huge health risk and injury risk for older adults. The definition of a fall is that when a person inadvertently reaches the ground or the floor, from whether they're standing or sitting, they reach the ground, which is called a ground level fall, GLF. This can lead to disability, loss of work, hospitalization, severe injury, and death. For older adults, they're at highest risk for serious injury or death from falls. What are the factors that influence the patient's safety, developmentally? For example, infants and toddlers and preschoolers. Most common hazards are injury, poisoning, aspiration, choking, drowning, burns. We know how much infants love to put everything in their mouth. So choking is a huge safety issue. It's important to teach our patients to keep it, maintain a safe environment. Place infants to sleep on their back, on a firm mattress, for example. Education for parents on removal of dangers in the home and play areas. Teach them that children up to a certain age need to be in rear facing car seats in the back seat. School-age children. Most common hazards are environmental safety, fights, bullying, weapons, abuse. Unfortunately, it's, children, coming to school with weapons, and then there's violence and, physical, sexual, psychological abuse. This is very common in school-age children. So educating them about how to stay safe is important. Teaching them about strangers, teaching them on how to deal with bullying, and, speaking to a safe adult. Adolescents, most common hazards are substance abuse, alcohol, suicide, and opioids. Suicide is at a very high rate for adolescents. The cues, how do you know, what are some of the cues you can look for? Failing grades, change in the way they dress, absenteeism from school, self-isolation, changes in interpersonal relationships. All these are cues, and we can educate our adolescent patients and their parents about recognizing these cues and where to find help. Then for adults, most common hazard is lifestyle habits, motor vehicle accidents like alcohol use, smoking, stress, illness, drugs. And it's extremely important to teach them about safe lifestyle habits, safe driving practices, defensive driving, and, and alcohol, limiting alcohol, smoking, how to manage stress, how to manage illness. And then finally, the older adult. The common hazards are motor vehicle accidents, burn, injuries, wandering for dementia patients, and falls. The risk factors is their physiological changes, polypharmacy. They take so many medications. The medication interactions cause them to develop, certain issues, health issues, cognitive changes. Then they have dementia, right? Then they have acute and chronic illnesses that they deal with. Factors that influence patient safety on an individual level. So these are the individual risk factors. For example, workplace culture, safety culture, workers' attitudes and beliefs, and the resources they have. So risk factors are lifestyle choices. They have sometimes dangerous jobs like construction workers, utility repair, law enforcement, educating about texting and driving, how to manage stress, anxiety, fatigue, making sure they're taking their medications or managing their illnesses. Then we have impaired mobility, like for muscle weakness caused by muscle weakness, paralysis, abnormal gait, poor coordination, balance issues, falls, injuries. Another individual risk factor, is sensory, cognitive, and communication impairment. Risk factors for cognitive impairments include dementia, delirium, depression, altered concentration. This leads to orientation changes, which lead to falls and burns. Visual, hearing, tactile, communication impairments such as aphasia. There's lack of ability to express their needs. Limits makes them vulnerable to health risks. Reduced health literacy, not knowing and not having the knowledge about their, health conditions, unable to understand information and make safe decisions, also impacts their safety. Economic resources, risk factors are homelessness, depression, substance use. This can lead to injury, lack of access to health care, which can also lead to illness. Lack of safety awareness, lack of knowledge of home, workplace safety practices. Now, risks in healthcare agencies that patients are faced with, right? And it affects their safety is medical errors. When planned actions are not completed as intended, or wrong plans of care are used. That's why it's so important to properly plan the care for a patient. Error prevention and patient safety are emphasized through the Joint Commission's National Patient Safety Goals, the Speak Up campaign, the National Quality Forum, which requires serious reportable events, SREs, associated with surgical invasive procedures, product devices, patient protection, for example, unsafe discharges, deaths, suicide, serious injury, care management, falls with injury, pressure injury incidences, central line associated bloodstream infections, CLABSI, environmental, radiological, potential crimes. All of these are considered serious reportable events and are required to be reported. And CMS, the Central Center of Medicaid Services, has never events, which are also similar to the serious reportable events. So these are all reportable events in healthcare settings. Procedure-related accidents. There's a surgical procedure, and, something goes wrong. Equipment-related accidents. For example, when you're lifting a patient up at the Hoyer and you're not using the proper procedure and the patient falls and gets injured, that's also a reportable event. Chemical exposure, right? Then you have workplace safety. That's an issue in a lot of hospitals. That's why in some of the hospitals here they have these huge signs reminding people that violence against a healthcare worker is considered a crime, right? Then you have falls. So now, factors that influence patient safety, the risks that we have in healthcare agencies, we have intrinsic factors and extrinsic factors. Intrinsic factors are biochemical, altered cognition, altered mobility, sensory deficits, and it's a list of these over here: toileting problems, medications, and extrinsic factors are extrinsic, outside, right? We have communication issues between healthcare workers and patients, education issues, not providing enough education, physical hazards, for example, liquids on the floor or cluttered areas in the room, electrical, cords or in their walking path where patients can fall. Then you have the competency of healthcare workers, right? How well are they trained, and how competent are they in doing their job? So these can pose safety risks, for patients. So now we're going to talk about how to use the nursing process that we talked about last week in making sure that we keep our patients safe. The first stage is assessment. It's recognizing cues. During the assessment phase, assessment process, we have to thoroughly assess each patient and the environment and critically analyze findings and compare them with those that we expect to ensure that you have a thorough database needed to make patient-centered decisions and provide safe patient care, right? So patient's perspective, assess for what are their values and beliefs about safety, about being in a healthcare setting, their knowledge of how to adapt to safety risks. Find out the patient's perspective. Then getting the nursing history. This is part of your assessment. Medical history, medication history, psychosocial and cultural background. Find out underlying conditions that they have that can create a risk factor. For example, patients who have orthostatic hypotension. If you know that they have orthostatic hypotension, you could make sure that they when they're changing positions, we can teach them and help them to move slowly. And then psychosocial and cultural background. Then in the examination, assess their cognitive status, their gait, muscle strength, coordination, any sensory deficits, cardiovascular status. What is their activity tolerance? How much activity can they tolerate without getting tired, causing them to become fatigued, exhausted, and then fall? Right? Developmental status. Look for what risks are associated with their development based on their age, right? What medications are they taking, right? Diuretics and sleep medications can cause dizziness and cause a patient to fall. We also need to assess the healthcare environment. Look for any hazard, clutter, IV pumps, devices, the positioning of the bed. Are there personal items in the call light within reach? Are there any risks for medical errors over there? Any disasters, For example, if there's a natural disaster coming, just make, assessing for these safety risks. Now assess also about, do an assessment about the patient's home environment. What access do they have to supportive care? What basic necessities do they have? Do they have heating and cooling in their house, right? Caregiver availability. Who is going to take care of them when they're at home? Assess for adequate lighting. Ask them about it. Adequate lighting, condition of flooring. What kind of safety devices do they have? Fire alarms. Do they have side rails on their beds at home or safety bars in the showers? How is their furniture placed? Do they have area rugs? What about food preparation? Any risk for foodborne illnesses? Space heaters are a huge fire risk. Ask them how they use their space heaters. Then look, and these are all fall risks that you can assess for. Then we have psychosocial. Assess for caregivers' knowledge and willingness. Do they have a caregiver who has the knowledge to take care of them and is willing to take care of them? What is their economic status? Can they afford these assistive devices and medications? Then we have the analysis and diagnosis phase. What are the nursing diagnoses that we can possibly use in case of, safety? We have risk for injury, impaired cognition, confusion, lack of knowledge, risk for poisoning. So what outcomes can we expect? What are our expected outcomes? We have patient remains injury-free at 1 month, for example. Patient adopts safety precautions at work in 1 week. Patient removes environmental barriers in the home in 1 month. So these are smart, measurable outcomes that we can, utilize. What are the setting priorities and collaborating with the team? We have to prioritize our outcomes, right? Our nursing diagnoses. What are the immediate risks of the patients, their developmental stage, level of health, lifestyle preferences, cultural needs? For example, for an older adult, the priority risk is falls from injury, right? And so you set your priorities. So, for example, impaired cognition or risk for injury would be your priority. Collaborate with the patient, caregiver, and healthcare team to reduce safety risk. How do we implement this? The implementation includes reducing the risk of falls and accidents, teach them about safe driving tips, use of assistive devices, safe medication use, regular toileting schedule, teach them to install safety fixtures at home, grab bars, smoke alarms, provide resources, neighborhood resources to help them maintain their independence. Maybe they can even use a occupational therapy consult. Encourage independence. Annual vision hearing screenings, strengthening exercises, health promotion, environmental interventions, safety with oxygen, food, fire, neighborhood, poisoning, medications, pathogens. These are all very important to educate the patient about. Now let's talk about safety in the healthcare. These are the different points in healthcare. We have fall prevention, restraints, side rails, fires, electrical hazards, and seizures. Falls. When a person falls, and reaches the ground level fall, 50,000 people die each year from falls in the United States. It's a top adverse events in hospitals, and then it results in severe injury, death, and disability. It's important to implement a comprehensive fall prevention approach to prevent these falls. So one of those approaches is hourly purposeful rounding. That means you don't just peek in there and say, "Hey, how you doing?" No, it's supposed to be purposeful. For example, be proactive, systematic, nurse-driven, evidence-based interventions, color-coded wristbands, hazard-free environments, taking universal precautions. This is a list of universal precautions. Please read over them. They're extremely important. Helping the patient familiarize themselves with their environment. Have the patient demonstrate how to use the call light. Make sure the call light is within reach. Make sure the patient's personal possessions are within reach. Their phone, their cell phone, their glasses, things like that. Have sturdy handrails in the bathrooms and hallways. Place the hospital bed in the lowest position. Keep the bed brakes always locked. And keep the wheelchair locks on in a locked position. Non-slip, comfortable, well-fitting footwear for the patient. Using night lights, keeping floor surfaces clean and dry. Clean up anything that's spilled, promptly. Keep the patient areas uncluttered and follow safe patient handling practices. These are all important to prevent falls. Then we have restraints. Allowed only if it reduces the risk of patient injury or injury to others, prevents interruption in therapy, and removal of life-saving equipment. This is the only time restraints are allowed. It's not a solution. It's a temporary mean to provide safety for them and others around them. Always use other alternatives before just jumping to placing restraints. Federal and state laws prohibit Medicare and Medicaid certified nursing homes, for example, from using restraints unless they're medically needed. Only in emergencies can restraints be applied without the resident or family member's informed consent. The optimal goal for all patients is a restraint-free environment. That's our goal, right? What are the different types? We have physical restraints, physical or mechanical devices, or materials or equipment that immobilize or reduces movement, right? For example, mittens or, wrist restraints or belt restraints. All of those are physical restraints. Then we have chemical restraints, which are medications such as anxiolytics or sedatives that relax the patient and, sedate them so then they're not pulling out their life-saving devices or hurting themselves or others. Complications from these restraints, from this immobilization, because now they're restrained. What are the different complications that you can expect? Pressure injuries, and you have to always make sure that they're not too tight. Always inspect the skin. Pneumonia, because they're not moving now, so now they don't have they have breathing problems. constipation, incontinence, humiliation, right? Agitation, death from restrictive breathing and circulation. These are all complications from restraints. What are the alternatives to restraints? Orient the patient to their environments, provide supervision in the form of a sitter, diversional activities, place them near the nurse station so they can be frequently monitored. De-escalation, we need to learn as nurses how to de-escalate the situation. Verbal interventions for aggressive patients, visual and auditory stimuli, engage them in something, relaxation techniques, exercise and ambulation schedules, attend to them frequently through their toileting, food and liquid, pain management. Sometimes patients are agitated because their basic needs aren't being met. They need to use the toilet, or they're in pain, or they're hungry. Camouflage IV lines with clothing, like with the stockinette, so they don't pull on them. Evaluate effects of medications. See if there's any side effects of the medications causing them to get agitated. Discontinue bothersome treatments as soon as possible. So, for example, if they have a urinary catheter, do they really need it? Discontinue it if that's what's bothering them. Use protective devices, for example, hip pads, helmet, skid-proof, non-skid slippers or mats near the bed. Side rails. They help increase mobility and stability when repositioning. They increase the risk but they do increase risk of falls because patients attempt to climb over them to get out of bed and then they get strangled and get injured. Most common form of restraint is the side rails, but it's not a restraint when two rails are up and the patient has a route to exit the bed safely and to maneuver freely within the bed. In that case, it's not considered a restraint. It's used to prevent a sedated patient from falling out of bed. Then if the patient is sedated and you're scared that they'll fall out of the bed and you put up the side rails, then it's not considered a restraint. Do not use for a confused patient determined to get out of bed because they will try to go over them and they'll get strangled. So side rails. Assess the patient's mobility status, and responsiveness to instructions. Bed should always be in lowest position. Always know the agency policy. First, focus on the cause. What is causing this patient to get agitated? Is it a response to new medication? Is it dehydration or pain? Place the non-skid mat alongside the beds. Just in case there's a fall, they don't have a serious injury. Hourly purposeful rounding, which includes checking for toileting, food, liquids, pain, and other needs. Fires. Fires are another hazard. Always keep the phone number for reporting fires visible on the telephone. Know the fire drill evacuation plan. Know the location where the fire alarms and exits, extinguishers, and oxygen shutoffs are in your work area. The mnemonic race, rescue, activate alarm, confine the fire, and extinguish the fire is an important acronym used in healthcare facilities. Electrical hazards. No agency policies. Use properly grounded and functional electrical cords. Remove and designate for repair equipment that is not, if the equipment is not working or if you see sparks coming out when you plug it, report it immediately and do not use it because it's a fire hazard. Seizures. General tonic-clonic seizures, GTC. They're called GTC seizures. They are hyperexcitation, disorderly discharge of neurons in the brain, leading to sudden, violent, involuntary series of muscle contractions. It's episodic. It causes a loss of consciousness. Patient can fall if they're standing, rigidity of muscles, and that's called the tonicity. And then you have the clonicity, the jerking of the muscles. So what are the risks? You can have musculoskeletal or head injury as a result of fall, or striking a body part against a hard object when they're during the seizures. Grand mal seizures, what are the signs and symptoms of that? So before the seizure starts, they may experience an aura, a bright light, smell, taste. Before it starts, it's kind of like a warning sign. During the seizure can last about 2 to 4 minutes. They can cry and then sudden loss of consciousness with falling. Tonicity, then clonicity, then shallow breathing, cyanosis, and loss of bladder and bowel control. All of that can happen during the seizure. After the seizure is the postnatal phase is amnesia. Sometimes they don't remember what happened, or confusion, and then they fall into a deep sleep, right? Status epilepticus is a seizure that is repeated. It repeats constantly. It's long, 5 minutes, without gaining, and in between the patient does not gain consciousness. This is a medical emergency and requires treatment and intensive monitoring. What are the seizure precaution goals? To protect the patient from traumatic injury, to position for adequate ventilation and drainage of oral secretions, and to provide privacy and support following a seizure. So these are seizure interventions that we need to take. When the seizure begins, stay with the patient. Note the time it started. Observe the sequence. Call for help. Call for help right away, but you need to stay with the patient. Just in case you need something, that additional person will be there to help. Track how long the seizure lasts. Notify the healthcare provider immediately. Position the patient safely. If they're standing or sitting, ease the patient safely to the floor. Protect the head by cradling it in your lap or placing a little pad under the head. Do not lift the patient from the floor to bed while seizure is in progress. Clear the surrounding area and furniture. Anything else, if they're seizing, move everything that can hurt them away from them. If the patient is in the bed, remove pillows, raise the side rails. If possible, turn the patient to the side with head slightly tilted forward. Do not restrain the patient. Try to remove their eyeglasses. Hold the limbs loosely and try to loosen the clothing so they don't, suffocate. Right? And then never force apart a patient's clenched teeth. If you see them clenching their teeth, don't try to move, try to open their mouth with your fingers, right? Tongue depressor or something. Now, if, for example, insert a bite block or oral airway in advance only if you recognize that the seizure is about to start. So this is before the actual seizure starts. If you recognize it, then you can put a bite block or, something to protect them from biting themselves. As the patient regains consciousness, reorient the patient and reassure them. Assist the patient to the safe position, a position of comfort in bed with side rails up, one rail down for easy exit, and the bed in the lowest position. Then conduct a head-to-toe evaluation. Inspect oral cavity for breaks and mucus membranes from bites or broken teeth. Look for bruising, skin injury to the bones and the joints. It's extremely important also to educate family members on how to stay safe. So we call this the 3 S's of seizures. Stay with the patient, keep them safe, and keep them on their side so they don't, aspirate in their oral secretions. Finally, the last stage of the nursing process, evaluation. Once we, implement our nursing interventions, how do we evaluate them? We have safe, the patient has a safe physical environment. A patient whose expectations have been met. Patient and family are knowledgeable about safety precaution. Patient is free from injury. So these are ways we can evaluate the care that we provide the patients, continually reassessing the patient and family's need for additional support services such as home care, physical therapy, counseling, further teaching. A safe environment is essential to promoting, maintaining, and restoring health. Overall, your expected outcomes include a safe physical environment and a patient whose expectations have been met, who is knowledgeable about safety factors and precautions, and who is free from injury. That is it for the lecture on safety, patient safety. I will see you in class.